But let's focus for 20 minutes or so, I'll try not to talk for too long, on prostate cancer. Prostate cancer now is a very common disease, gets a high profile because people like, for example, Andrew Lloyd Webber gets prostate cancer, immediately goes to the Daily Mail and tells his story, or the Mail on Sunday, I think it was, tells his story about his treatment and so on. So it's in the media. And remember, more than 10,000 men die from prostate cancer every year. Many of them are in their 60s, 70s, and 80s. And it used to be regarded, well, you've got to die of something, and at 60, 70, 80, what's the big deal? These days, everybody, at least all my patients, want to live forever. And they're not too happy if they're sort of written off on the grounds that they're getting old. So every man in this room, how scary is this, has a 1 in 10 chance of developing prostate cancer. That is a scary statistic. And it's probably related to westernized lifestyle. So just to remind you GPs who don't always focus on urological matters, this is the prostate sitting at the base of the bladder. There behind you can see the seminal vesicles and the vasa connecting the prostate to the testes. So it's an organ of fertility, it's a reproductive organ, and as men get older, their prostates get larger, and they are prone, just like women are prone to breast cancer, men are very prone to prostate cancer. So this is the number of newly diagnosed cases of prostate cancer in the UK, altogether about 36,000 men this year will have been diagnosed from prostate cancer. You can see the age groups affected, it's mainly men 60 plus. And of course, with PSA testing, the number of diagnoses is going up all the time, and we'll come back to that rather slightly fraught issue of PSA testing. And I think Mark Speakman, who's going to speak next about mainly benign disease of the prostate, may have some comments about that as well. Well, these are the risk factors for prostate cancer. The most important one is family history. I'm always amazed how many of the patients I see diagnosed with prostate cancer have a family history of it. Their father had it, sometimes their uncles had it. And about 5 to 10% of men diagnosed with prostate cancer are part of a positive family, have a positive family history. So just as there are families in the UK and elsewhere of women, all of whom get breast cancer, some of whom have prophylactic mastectomies, so there are men, all of whom get prostate cancer, and they're destined to get prostate cancer. And we now, as a result of the work that, for example, Professor Eales at the Royal Marsden has done, we now know there are about 35 or 36 genes associated with prostate cancer, so-called prostate cancer susceptibility genes, including BRCA1 and BRCA2, which are breast cancer susceptibility genes. Surprise, surprises, there are links between breast cancer and prostate cancer. So certain genetic profiles mean you're more susceptible to than normal to prostate cancer. And so we might be able to target our screening to men who have a certain genetic profile and who are destined to develop prostate cancer in the future. We might get away from the difficulties of PSA screening the entire population by that means. So these are some of the risk factors for prostate cancer: getting old, being a man, of course, family history, and ethnicity. So prostate cancer is more common in Afro-Caribbean people. Probably a Western diet, probably too many Big Macs with saturated fat and other types of saturated fat, maybe lack of sunlight. It seems to be more common in northern European countries, especially Scandinavia, and maybe, it's not absolutely clear, obesity is a risk factor for prostate cancer. It's certainly a risk factor for other types of cancer, and we've already been talking a lot about the tsunami of obesity that Peter Amoroso mentioned. So these structures were, the neurovascular bundles, NVBs, are important to urologists because these are the structures that we try and preserve when we're doing surgery on the prostate. And they were described by a urologist called Patrick Walsh at Johns Hopkins University, and he was the first one to realize that these very fine, delicate nerves run behind the prostate and can be preserved. Of course, they're affected by radiotherapy and by other forms of treatment of prostate cancer. And these nerves supply the penis with neurovascular supply, and if they're interrupted, then the patient loses their erection. So one of the fear of men of developing prostate cancer is that their sexual function may be affected, and most treatments for prostate cancer do carry that risk. We'll talk a bit more about that later. Well, this is the anatomy of a prostatic duct, which is rather like a lactiferous duct in the breast, actually. It arborizes through the prostate, and there are about 10 or 20 of these arborizing duct systems within the prostate gland, normally the size of a Spanish chestnut, enlarges to the size of a tangerine, and then maybe an orange, and perhaps even a grapefruit. Urologists love to compare prostate size to some kind of fruit or citrus fruit or nut or something. That's often we're trying to find the exact comparison, but it should be the size of a chestnut, and as it enlarges with BPH, part of the reason for that is increased activity of these glandular substances. And of course, the role of the prostatic glands is to secrete PSA, prostate-specific antigen. Some people call it promoter of stress and anxiety, because if your PSA is raised, have you got cancer? Have you got BPH? Have you got infection in the prostate? PSA's job is to liquefy semen after ejaculation, and it's bound to proteins within the bloodstream, and we can measure PSA levels in the blood, PSA levels bound and free, and it's one indicator of a problem in the prostate, but it's certainly not the best marker in the world for prostate cancer. Of course, the prostate is an endocrine organ under the control of both the testes, secreting testosterone, and importantly, especially in the light of abiraterone, a drug that I'll mention towards the end of the talk, and the new hot drug on the street for prostate cancer, some androgens also secreted by the adrenal glands, and blocking both the testes and the adrenal glands, which is what one of the things that abiraterone does, may give you improved control over just blocking the testes, which is what you do with drugs like Zoladex and Prostate. So this is an illustration of when a prostate cancer develops, it requires a blood supply to grow. And if it metastasizes, it develops new blood vessels. So one of the new approaches to treating not only metastatic prostate cancer, but metastatic tumors elsewhere, is to try and interrupt the so-called angiogenesis. So imagine this is a slightly scary metastasis sitting in the skeleton of a patient with prostate cancer. The metastasis secretes angiogenesis-inducing proteins, and new blood vessels form, and as they attach themselves to the metastasis, then the metastasis gets a food supply, a blood supply, and it starts to grow. So inhibiting that with drugs like thalidomide, used particularly in the treatment of myeloma these days, and newer forms of anti-angiogenesis compounds is another treatment approach to the management of patients with prostate cancer. Well, of course, we live our lives and we're subjected to hits on our DNA from various carcinogens and radioactivity, background radioactivity here, there, and everywhere. And as you get older, you get more hits on your DNA. And exactly in the same way that colon cancer develops within the large bowel, then in the prostate, hits on the DNA in various strategic locations result in carcinogenesis, and you need multiple hits on your DNA before you develop prostate cancer, and we're beginning to tease out those with the knowledge of these cancer susceptibility genes that I mentioned. Once you've had those strategic hits and one cell develops into 2 to 4, 4 to 8, etc., then a nodule develops in the prostate, which gets larger and begins to infiltrate surrounding structures, including the seminal vesicles, and pushes backwards on the rectum, sometimes producing symptoms within the rectum. And one of the places where tumor spread occurs is through the neurovascular bundles, which we try and preserve when we're doing prostate surgery, but we have to be careful that we don't cut through the tumor, as you can imagine in this diagram, leaving cancer cells behind, because they have a particular propensity to grow in that particular direction. And if they don't grow in that direction, they also metastasize first to local lymph nodes, as shown on the right, and then metastasize to the skeleton particularly. For reasons that's still not completely clear, the bony skeleton is a place where prostate cancer metastases are most likely to develop, producing bone pain and osteosclerotic metastases. Well, that's just an illustration that a reduction in flow rate is a sign of prostate problems. This is one of the Irish rowers in the Athens Olympics, and he probably drank a little bit too much fluid. He's actually got quite a good stream. Patients with prostate problems have a poor stream, of course. Rectal examination can detect a nodule, and I think it's one of the things that GPs don't do enough of is rectal examinations, to get good at palpating nodules in the prostate, because if you can feel a nodule in the prostate, it's nearly always a hard nodule, like a hardness of your knuckle. They've nearly always got a prostate cancer on biopsy. This is a lady urologist performing a rectal examination on a slightly surprised-looking patient. And I've just mentioned PSA. We're desperately searching for a better marker than PSA for prostate cancer. The main problem with PSA, it goes up in BPH as well as prostate cancer. So it just tells you there's something wrong with the prostate. It's not cancer-specific as a marker. And after it was discovered in 1970 by Wang et al., so it's now 41 years of age, the PSA test, and surprise, surprise, it's still controversial and it's still used, but it isn't as good as it could be. There has been a randomized study on PSA screening from Europe with 182,000 participants, and they found that using PSA in these patients who'd not been tested before had a 20% reduction in mortality. But the problem was that it also resulted in overdiagnosis of Gleason pattern 6 cancers, which are regarded really as low-risk cancers, might be best not diagnosed. We'll talk a little bit about active surveillance. The problem with the PSA test that if it's positive, if it's more than 4 in a man, then the patient has to have a biopsy. And we always worry about biopsies because not only do you run a risk of getting bleeding in the urine and bleeding in the semen, you also can produce infections which can be quite severe, septicemia. We've actually reduced that at the prostate center recently by switching from gentamicin and ciprofloxacin as prophylaxis to amikacin as a intravenous injection just before the biopsy. And we haven't seen any sepsis in the last 8 months or so since we switched. So I think that might be a useful thing. Incidentally, doctors and patients who've traveled recently abroad seem at higher risk of developing septic complications from biopsy than other individuals. And of course, a doctor having a prostate biopsy is the very last person that you want to have problems. Doctors tend to have more complications than any other particular group of patients that we look after. This is a histology slide looked at St. George's on a patient who's undergone a prostate biopsy. Those are the pathological features of prostate cancer, and they can be graded from 1, which is well differentiated, down to 5, which is poorly differentiated. And because prostate cancer has patterns that vary from parts of the tumor, then you take the two scores, two predominant areas, and add them together. So the top score is 10, the bottom score really is 6 because you don't see many 1s and 2s. 6 is low-risk cancer, 7 is medium-risk cancer, 8, 9, and 10 are high-risk cancers. They're the type of cancers that you don't want to get. So in the same way as the management of breast cancer, that the breast cancer surgeons and oncologists are managing breast cancer according to the pathological characteristics of the breast tumor. That's what we're beginning to do with prostate cancer. The pathology can really affect the way in which we manage patients. That's just a scan showing a orange-colored, brown-colored tumor in the prostate. We're getting better now with MRI scanning at actually assessing where within the prostate the tumor is in the same way as you can with breast cancer in the female breast, not as accurately. And we do bone scans to look for metastases. This is a patient with a PSA of over 100 with multiple metastases affecting the entire skeleton. Quite a useful test for metastatic prostate cancer. And there's just an MRI showing tumor in the spine and an X-ray showing the osteoblastic secondaries in the pelvis of a patient who's already undergone bilateral hip replacement. Well, this is just a patient story. Just turn the volume up.
At the beginning, they thought I had a urine infection. They put me on antibiotics for 2.5 years, despite the symptoms recurring all the time, and despite many checks on the urine cultures. They couldn't find any infections at all, yet they still insisted I had an infection. And after about a year, I had a cystoscopy. Again, they found, I can't remember all the technical terms, I don't have the papers with me, but they found some slight abnormalities, but decided it was nothing to get too excited about, and just left it and gave me more antibiotics. So the net result was that that was going back to February 95 when I first had the first symptoms. And by August 98, I got really fed up with this. I was in Switzerland at the time climbing a particular mountain, and the symptoms got so bad that I thought I had to do something about it. Well, prior to the surgery, we discussed the options that were available to me. We could wait and see what happened and perhaps hope to get away with it, or you could have a radical prostatectomy. Brachytherapy was in its infancy at the time, but that was an option. I think I could have had it done in Leeds at the time, from memory. But that was about it. There were just the three things. So in the end, I decided to go the whole hog and get on with it, because I think when you get to the stage that I was at, it's probably better to be without the main problem and then deal with any residual problem that may arise later on. Well, it's a pretty fast ball when you get the diagnosis anyway, but then to find out that you've gone through to all that trouble and not perhaps not been successful in eradicating it is a bit difficult to deal with. But you know, one can come to terms with these things. You just got to get on with it. If you dealt that particular hand of cards, you've got to play them as best you can. In my own case, I had the radical at the end of September in '97. My PSA went down to 0.5 immediately following the operation, and then it started. And I'm going back a few years now, but it started to rise again. Ideally, it should have gone down to 0 or 0.1, but it didn't. And it started to rise again, and we decided, in conjunction with Professor Kirby, that the next stage of treatment would be some radiation. The Casodex kept the PSA down to 0.1, 0.2. I got fed up with it because it does have a few side effects, and I said, right, I understand that intermittent Casodex, you know, a month on or a month off, or 3 months on, 3 months off, may do the trick, and maybe we've dealt with everything. So I put the Casodex back in the cupboard and stayed off it for a year. Gradually, having been not taking Casodex for some considerable time, my PSA started to rise, and Roger Kirby and I decided that we would let the PSA get to 10 before we did something about it. But being an eternal optimist, of course, I let it go to 23. I was coughing and spluttering and wheezing a lot. And I'm going back to January of this year, when I was skiing for a month, and of course minus 20 degrees up a mountain doesn't do damage lungs any good. So I had a bit of trouble there and started to cough a bit of blood in sputum and stuff like that. So we had a look at that in March and April of this year. Following which Roger recommended that I had a bronchoscopy, and he handed me over to a chest physician. The chest physician said, yeah, we'll have a look around and see what there is. So I had a CAT scan which showed multiple bits and pieces in both lungs, which I chose not to think that it was metastasized prostate cancer, because I understand that it's highly unusual that that actually happens. But of course, as it transpired, it seems to have happened in my case. So 4 months ago, I started a higher dose of Casodex, and my PSA went down from 23 to 17 to 7, and it's now, 3 weeks ago, it's 4.7. I don't think you ever do come to terms with it, really. It's a hard thing to realise that you're not immortal anyway, as I've always believed that I am, and probably most people do. But it's a bit of a shock to find that you're not. I suppose you've got to go for something at the end of the day, but you do the best you can in the meantime. There's not really a lot I can say about that. How people deal with it depends on how mentally tough they are, I suppose, at the end of the day.
I think that the reason I put that up is sort of tells the story about the delayed diagnosis, and he's still very angry. He comes from Jersey, actually, that patient, and that film was made about 4 years ago. Since then, he's been well controlled on bicalutamide, Casodex, and just recently, his CT scan showed recurrence of the chest metastases. So he's got himself a flight to New York, and he's having this very expensive immunotherapy called Provenge therapy, which has been shown to improve life expectancy in metastatic prostate cancer by about 3 or 4 months. Costs $100,000. He's quite a well-off patient, so he's gone off. He likes to do his own thing. He doesn't necessarily do what I tell him to do. But in a sense, it tells the story of kind of the sort of human side of it. I think it's quite educational and a little bit touching.